My name is Dr. Amos Kibata. I'm a retinal surgeon at CTI Hospital. We are talking today about our experience in the Kiambu County using a mobile camera-based screening program. Previous experiences have been from static cameras. That's Kenyatta Hospital, Nakuru, Migori, but we don't have yet statistics or results from using a mobile-based camera. From studies done in Kirinyaga, Nakuru, and Nairobi by Dr. Nyawira in 2017, they found that only 13% of diabetics attending the diabetic clinic had had an eye exam within the previous 1 year, and only 26, a quarter of them, have ever had an eye exam since they were diagnosed with the disease. Studies done by Dr. Gishohe, a review of the camera-based experience at KNH, showed that the introduction of that static camera in the diabetic clinic resulted in a twofold increase in the referral from the diabetic clinic to the eye clinic, which was just upstairs, and a threefold increase in lasers and injections by the introduction of that camera-based screening program in the diabetic clinic. So we know that we have a problem in terms of diabetics not having the eye exam, and we know that a camera results in a great change in behavior or eye exam or experience when it is introduced. However, that is a static camera, and the probability of equipping every diabetic clinic in this country with a static camera is slim. So we wanted to know what would happen if instead of a static camera, a camera moved from clinic to clinic. And we decided to use a trial first on 3 hospitals: Gatundu level 4, Gegania level 4, Kiambu level 4. These were largely rural hospitals, except maybe Kiambu, you could say it's in a major town, but Igagania and Gatundu are largely rural. And the study was very simple. We just reviewed all the patients who attended the diabetic clinic on that day, and every patient was offered a non-dilated retina photographs at the end, at exit. So it wasn't done at the beginning, it was at the exit. It was the last thing before they kind of left the clinic. Each patient who was identified as having a problem was given a coupon, which he was to present to CTI Hospital within 30 days. And that coupon basically waived the consultation fee. So if you came with that coupon within 30 days of your referral, you did not pay the consultation fee of 500 shillings. We used a Forus non-mediatic fundus camera, which, and you can see how it looked like. It's fairly portable, very easy to carry around. It needs power. It needs a table, and it's not very easy to get photographs because the user training required or the user confidence is significant. But once the user learns how to use it, it gives them decent photographs. So in our outcomes, we screened 674 patients in the OPD diabetic clinic between those 3 hospitals. We had a 77% response rate, which means that even though the camera was there, it was free, it wasn't painful, it wasn't going to take a lot of time. It takes about maybe 5 minutes to get a good photo. Still, a quarter of the patients declined. And the major reason was they were just tired. They came to the clinic at 7, the doctor arrived at 11, they were being seen at 2, and they're just fed up, they wanted to go home. Or they were coming from far, they really did not want to spend another 5 minutes there. And then the other major reason was a perception that they don't have a problem. Why are we looking at their eyes? They can see well, they have no problem. So there was no perception of need, and so they walked out. In terms of the overall referral rate, we see that it averaged at 32%. That's the column on the extreme right. So we referred 1 in 3 of all the patients who had a photograph because they had a problem of one type or the other, either diabetic retinopathy, they had cataracts, the pressure was high. Those are the major reasons we referred, visually significant cataracts, diabetic retinopathy, and elevated IOPs. In terms of the people who we referred, the 1 in 3 who we referred, only 30% actually presented at CTI Hospital in that 1 month. Remember, within the month, that's when the coupon applied. It was free. Otherwise, if you came after 30 days, then you paid. But within that month, only a third of the people who we referred, who we identified they have a problem, we explained to them, We waived their consultation fee, so they were just to get to the hospital. Only a third of them came within a month. And a lot of them, the excuse was they've never been here, they need somebody to bring them, or they don't have transport, or they're too sick, one thing or the other. But we were shocked at the response rate. Only a third of the people actually came. In terms of specifically diabetic retinopathy referral rate, remember the referral rate of 1 in 3 was everything, suspected glaucoma, cataracts, and diabetic retinopathy. If we removed cataract and glaucoma, 16% is what was our referral rate for specifically diabetic retinopathy, which is maybe 1 in 5 or maybe 1 in 6. So once they came, in terms of now they've come to the hospital, we have identified and confirmed that they have a problem, and we've given them a solution, either surgery or laser or injection or one thing or the other. In terms of that conversion from presentation to actual procedure, we saw a wide variation between month on month. So in 1 month, you had 67%, which means 2/3 of all the people who came actually booked for the procedure. And in 1 month, only a fifth of them came to get the procedure done. And the major reason was finances. We discovered that of all the diabetics we saw in the diabetic clinic, less than a third have NHIF membership. And the ones that were members of NHIF, only less than half of those were actually active contributors. So it's even less in terms of the people who have NHIF. So the challenges we experienced in this program is that, one, getting the go-ahead from the counties was a huge, huge undertaking. It took us a year to just get that MOU signed, and we were offering a free service to the county. Two, lack of infrastructure. A lot of those diabetic clinics didn't have rooms, they didn't have tables, they didn't have power, they didn't have a place to put the camera. Infrastructure was a big, big issue. And then inefficiency at the diabetic clinic, so that patients really were just wanting to go home and not interested in this camera because they had stayed so long and they were so hungry and so on and so forth. And then the camera, the type of camera that we took was not very easy to use. And then, of course, the absolutely shocking low penetration of NHIF among the diabetic patients. In terms of the successes, we demonstrated that we can increase screening from 13% or 20% to 77% just by having a camera moving around from one clinic to the other, and that camera was able to identify those at risk. There was almost 100% confirmation of the people who we referred and the diagnosis that was reached at the hospital. And that one mobile camera can actually cover several facilities, and so we do not need to actually have static cameras everywhere. We can use a mobile-based camera which will cover several programs and several clinics. Thank you very much.